Hello, everybody. This is Jazzeeb Mann. I'm the marketing director at ReMedi Health Solutions. We are a EHR consulting firm in Houston, Texas, joined by Fatima Paruk. She is the chief medical information officer at Microsoft, as well as Sonny Hyare, who is the chief executive officer at ReMedi Health Solutions. Today, we're going to be digging into some questions about data migration, data strategy, all surrounding healthcare. So let's just go ahead and start off with the first question.
Thanks for having me.
So what major challenges are healthcare providers dealing with that are directly related to how they use data?
Yeah, there's a ton of challenges. And Sonny, feel free to chime in here as to what you are seeing and your opinions on some of this stuff. But I think as it relates to health data, healthcare has very much been left behind as it relates to the data estate. I have found that healthcare data has generally not been treated as a first-class citizen throughout my career. It's very much been an afterthought where data has been collected more and more now, increasingly in electronic medical record systems. So we do have the ability to extract structured data. But unfortunately, in the setting of a lack of culture where data is respected as a first-class citizen, what's happened is it has resulted in a lot of free text data, a lot of data that is certainly not structured and not able to be utilized for secondary data purposes. It also makes it really difficult as you're thinking about understanding how best to make informed decisions about the best possible plan of care across a number of different settings of care. Our patients are a lot more complex these days. We're responsible for managing patients, again, across different settings of care. We are responsible for coordinating care across a number of different settings. And often we just don't have the information that we need to the right person, the right place, at the right time. The other thing is, again, it needs to be within our workflows, our native workflows that we're used to leveraging, right, on a day-to-day basis. So if I'm utilizing an EMR and that's going to be the center of my world for documenting patient, courses and histories, I'd like to be able to understand what a patient has had at any other site or what their medications are without having to be reduced to a data entry clerk as a clinician. So these are some of the things that I'm seeing, across the last, decade or so as it relates to where we're headed. Certainly recent ruling on interoperability, it's been mandated, but we just don't have a way to get there for a lot of organizations. And so that certainly makes things a little bit difficult as well. Our system in the US is incredibly complex. And so as we think about the prior authorization, especially across different payers, that can sometimes be an interesting challenge as well. And then lastly, as we think about patient ownership and as patients manage their individual journeys, we really need to think about patient ownership of data and how that translates to transparency for health systems and how that data, again, can be utilized to unlock value and inform clinical decision making.
So with that being said, what could healthcare companies do better when it comes to their data?
There's a lot they can do. So one, treating data like a first-class citizen. And again, Sonny, I'm going to ask you to chime in here as it relates to setting up some of these systems appropriately. I think that's a really important first step. I think setting in place data governance structures is key. And then as it relates to the technology, I think that part is clearly where you all are the experts. So I'd love it to, if you chimed in a little bit on how you saw this coming to fruition.
I think one of the best analogies I heard was someone telling me that if your car broke down somewhere in Wyoming and you were from Tennessee, the mechanic would have more information on your car than you going into an ED in a similar situation, which is crazy. We're using these billion-dollar systems to collect data, take and provide care, yet they're not talking to each other, being the fact that we're in Houston. Two of the major hospital systems here across the street from each other aren't talking to each other. And so we look at that and we wonder, first of all, how much data are we actually collecting and what's meaningful? And then we look, why is this information not being disseminated across the nation? Why do we not have access to that? And those are kind of the things that we see healthcare providers kind of dealing with. And what you see is that a lot of health systems are using claims data to bring accuracy to data versus what's in the EHR and what the physicians are actually looking at. So as a provider, you're struggling. You're searching. You're spending a lot of time looking for where this information is, what this information is. It correct? Did this person do this or that? And that's where we see major challenges. And there's no integrity to this data right now.
Yeah, I'm certainly seeing that as well. Again, that was where I was going with the data governance and infrastructure sort of comment, right? I mean, the fact that even if we are getting outside data coming in, often there's this trust issue around it where we just don't know if the information is correct. Is it trustworthy? Is it something that I can make medical decisions about patient care upon, right? Because if we're not making the right decision based on that correct information, we could be actually causing harm.
Yes.
So, bridging all of these ideas into today, what has the current health crisis taught us or shined a light on when it comes to the efficient use of data?
I think COVID-19 has certainly changed our world in ways that are just unimaginable, right? If you had told me a year ago that we'd all be walking around in masks and, we'd have this pandemic that we were grossly unprepared for across the world, I don't think I would have believed you. But, overnight, it's amazing how things have, again, just changed. The need for on-demand and virtual care enablement has just gone through the roof. Prior to this crisis, what we had experienced was actually a very, very slow uptake of virtual care. So people were occasionally conducting a telehealth visit here or there. But in terms of recently, where folks have just adopted this stuff at scale, again, that was something that was completely and totally unimaginable. So, now that we actually have virtual care, and I do believe that it is here to stay, we can start to think about, what are some of these efficiencies that we need to have in place to actually make this successful and sustainable. What we're seeing is these individual telehealth visits are great because doctors can actually keep their schedules, right? So they can stay on track and, it starts at a finite time, it ends at a finite time. And often just by going digital, that process has certainly made things a little bit easier to adhere to. However, I'm also seeing that the value currently is limited because of the lack of integration. So telehealth is occurring, in the form of FaceTime visits. It's occurring over Zoom, like we're speaking today. It occurs on Microsoft Teams. And Microsoft specifically has done a lot of work on their Teams platform to really make it super usable. But what we're seeing is that there's still a long way to go as it relates to integration of these virtual care platforms with the system of records. So just being able to manage the scheduling, the billing, the coding that comes out of a standard virtual care visit, whether it's an outpatient visit or a virtual rounding visit that happens on the inpatient side. I haven't seen too many, great models that have come out to say, hey, hold on, this is going to work and going to make things super easy and seamless in the longer term. So I think, it's both an opportunity and a challenge, right? And so I think if we can overcome some of that stuff, I believe that we'll have longer term success as it relates to virtual care. That, again, it's innovation fueled by crisis.
It amazes me how much actually was available at that when COVID did start and the country started to shut down in March, how many tools were available to start getting people to start using these and get physicians. And I know that the government kind of took down some of the rules and which allowed for FaceTime, allowed for, WhatsApp, Zoom, any type of video or video conferencing was allowed. And I'm sure that's going to come back as COVID starts to go down. Some of these regulations will get put back on and things like that. But one of the things I'm noticing and seeing is that the EHR vendors now are the ones that are kind of slowing down this innovation process from a virtual standpoint. I'm noticing that obviously the vendors are picking and choosing what they want to use, but once again, there's just so much out there. And one of the biggest roadblocks for them is how they interface with the Epics or the Cerners of the world. And from an institution standpoint, they're just looking at, does this piece work with our current EHR? If so, we'll talk to you. Versus if you have no idea, we're talking about kind of companies that aren't necessarily in the healthcare space, but have been doing this video conferencing or these chat bots and things like that. They need to kind of get through the vendors before they can get to the hospitals and have these conversations, which I think is slowing down what potentially could be something amazing.
Yes, I see there's potential, barriers to adoption in the EHRs. The other barriers that I've seen are actually also just very human level kinds of things, right? So whether it is with the provider who just may not be technologically versed in some of these virtual care platforms, I've also seen that we need to really think very consciously about the patients that benefit from virtual care. There's certain patients, and I believe that every patient should be enabled, to be able to conduct virtual care visits. But we also need to think about developing the platform and the technology to suit people from different technological abilities. Grandfather is 99 years old and he's absolutely happy using an iPad. So I have no doubt that somebody who's even 99, could be able to conduct a virtual care visit. But what do we do for folks that don't necessarily have the best vision or the best hearing? And what are we doing as it relates to accessibility for a lot of these platforms? Because a lot of chronic patients that do need to utilize the system are not necessarily, again, perfectly enabled to take advantage of virtual care. So I think you being the implementation expert here, what do you see as the biggest challenge? Do you think it's the EHR? Do you think it's the clinician? Do you think it's the patient? And how do you plan to go off and make a difference in this space?
I think it's all three. You've got patients that are being asked to do things in specific tools or apps and not necessarily understanding the tech side of it or not tech savvy. And then I feel like the physician falls in the same place where they're being asked to do certain data entry things where if a physician's been practicing over the last 30, 40 years, they're truly not accustomed to this. And it's not benefiting, in their mind, is not benefiting them. From an actual institutional standpoint, there's a need for this. It's essentially their way of tracking of everything that's going on, not just from a financial standpoint, but from a clinical standpoint. And if we're going toward that value-based model, EHRs are the only thing that's going to lead us in that direction. And I understand looking from a private sector and some of the physicians that I went to school with who are single provider, kind of single provider practices, they're going to stay on the fee-for-service model as long as they can. Their answer to everything is, I'll see more patients to get back to the revenue I was making in 2012. So we look at these three things, and one of the things that we saw was how important this data was and how it was important especially during an implementation process where the ideology 5-6 years ago was an all or nothing type methodology. Either we're going to bring all the data in, and what we saw was, well, there was so much data and so much inaccurate data. How is that actually helping you? And then we had the none model where we brought nothing in. You had it in a view only in a legacy system. And what we saw was physicians for the next 6 to 12 months were seeing every one of their patients as a new patient. So you see volumes dramatically decrease. So that was why we kind of put an emphasis on how do we actually meet in the middle and how do we do this? And that way that you're getting integrity data into the new system, as well as getting the physician to not miss a beat when searching through the EHR. And our goal is to find that middle ground.
Yeah, I think that's a key point here as we're thinking about how data can actually enable innovation and new technologies and adoption, whether, again, it's virtual care or improving current workflows. I think what I'm also seeing is that a number of different organizations, as it relates to the fallout from COVID-19, are now trying to really understand how they can stay alive and, think about, either new revenue streams or recapturing a lot of that revenue that's been lost because a lot of the elective procedures, as you know, have all gotten canceled or put on hold, or a lot of the visits, that were occurring were not optimally billed for. And so I'm just wondering on what you think is, again, some of the stuff that, I really just want to understand what you're seeing in the market at this point and how you're helping with some of that revenue recapture at this point in time.
So some of the things that we're seeing from a rural space, and we've been doing a lot of work in the community and rural hospitals, they are struggling the most, especially when the stuff from CARES Act came out. The bigger hospitals kind of took a majority of that and much wasn't left for the rural hospitals. So when the government asked for the shutdown of elective procedures and things like that, that was a direct hit. And these hospitals are living 30 days. They got cash on hand for 30 days. So you can imagine what's happening there. And from the bigger hospitals, I think they'll be fine. I think they'll get through it, even though they lost a lot of money. I think they got help from the CARES Act, and they're starting to do their procedures again. they've got a lot more cash on hand to kind of get through this. But what we're seeing is you're seeing these hospital systems become leaner now. You're going to see these hospitals kind of take away from the administrative side. We're seeing a more push to add more clinical staff. And you're seeing, and this should have been done a while ago. I remember seeing a graph where there was literally an increase in and I know we can go through this. I can't remember the number now. It's like 20,000% or something, an increase in administrative staff. Yet the residency spots of 16, 17,000 stayed the exact same. Of course, the last 20 plus years. So that's something that we're going to see it kind of go back more into the clinical side of things and not be this overarching corporation. But I guess only time will tell.
I certainly see a lot of room, just to respond to that, for opportunities as it relates to process automation, leveraging AI and machine learning, which again is one of my sweet spots as we think about reducing some of that administrative burden and just the overhead, right? So that we can hire more clinicians, hire people that are going to be much more patient facing, who can actually deliver out on the care that needs to be administered. So I think, again, there's a number of opportunities that are certainly out there as it relates to improving efficiency and getting doctors and clinicians back to what they do best, right? Removing the administrative burden from them and just really getting them to deliver out on just care.
So last question here. So describe how the role of the electronic health record has evolved throughout your career and how you would like it to transform in the next 5 years.
Yeah. So as we were just talking about this, right? We've mentioned that it's certainly evolved from this place where, the EHR itself, as much as, it's now currently the center of the physician universe, it started as a tool really that was meant to collect codified data for the purposes of billing, right? Clinicians were not involved in a lot of those initial designs because, again, it was really meant for billing purposes only. What we've seen now is with the widespread physician utilization and adoption of EHRs across the field, we're seeing far more natural workflows. You're seeing many more physician technologists like myself and Sonny in this space. I think when we both started in this space, there were probably just a handful of us that really understood how EHRs truly worked and how to customize and create value out of them for clinicians. But, it's very promising that I'm seeing many more of us out there in the field today. So certainly I've seen that evolution. I'm also seeing that the EHR companies now need to, again, add value to maintain stickiness. So we're seeing increased consolidation in the field. So, about 10 years ago, I'd say there were hundreds of EHRs out there. We're certainly seeing it now that there's fewer and fewer larger giants that have taken over the market, whether that's on the inpatient side or on the outpatient or ambulatory side. We're also seeing increased specialization of workflows within EHRs according to specialty. So, it's basically looking at the type of content and so on that's available within EHRs for the purposes of clinical decision support, managing patient throughput, so on and so forth.
Yeah, I think when we started this, it was actually a little bit of a kind of a naive expectation on, hey, this is easy, this is fine, we can customize this and that. And it wasn't until we got a few years into it where we really started to understand what was going on in the background, how complicated this system was, and kind of what the true role of these large vendors were providing for the healthcare systems. And if I was to see some sort of transformation, I believe that whenever you think of hospitals or you think of clinics, you think of doctors first, and the health record should think of doctors first. At the end of the day, everything is built around a CPT code, and there's only one person that can put a CPT code in.
Yeah. Yeah, I mean, but again, that's why I'm so inspired by folks like you, Sonny. I mean, you certainly are the CEO of a company. You're on the business side, but you represent, the physician interest. You are, certainly one of the people that understands that more and more clinicians have all of a sudden become decision makers in the purchasing, in the design, in the implementation of these tools. And so I'm, very reassured that things are going to change, and they're going to change for the better, because clinicians are taking a stronger role in making sure these tools are efficient and relevant to clinical care.